if we talk about synthetic oxytocin, I guess the first thing to say is it's often used for induction. So whether it's the first used or often after prostaglandins, there's different mechanisms, different ways of inducing, but it's often, I could say more usually, it's sometime given to women being induced. So by definition, the woman's not at that point of readiness that we talked about. She's not going to have that massive number of oxytocin receptors. So she's going to need more than she would naturally produce. Remember, I said, in terms of millunits per minute, if that makes sense to you, 4 to 6 at the beginning of a physiological labor. And it's very uncommon for women to be induced or get such low doses in labor. We really have to give a lot more. But just to comment about that, and this was one of the findings of our report, is we can't give a lot to laboring women because of that massive increase in uterine sensitivity. Like, we can do research in adult males or animals and we can give them, 100 units straight away, but we couldn't do that to a woman in labor. She'd have a massive uterine contraction and harm her baby. So because of that extreme sensitivity, we can't give a lot of synthetic oxytocin to women in labor. So our finding was that the levels don't go up that much, 3 to 4 times maybe maximum in labor. So obviously, we want to avoid induction. We want to avoid interventions. And synthetic oxytocin, the other important part about it is that it doesn't cross into the brain. I haven't mentioned this, but if we look at the oxytocin molecule, maybe we'll put a picture of the molecule up there, but it's quite a simple molecule. It's called a peptide molecule. So it's made in the brain and comes into the body. But peptide molecules don't easily cross biological membranes. So biological membranes are actually lipid, they're like fat membranes, so you need something fat soluble. There's many things that are fat soluble. Most drugs are fat soluble, cholesterol based things, hormones are soluble, but not estrogen, progesterone, but oxytocin itself doesn't easily cross biological membranes. So it doesn't go, when we inject it into the body, it doesn't go back into the brain. So it doesn't give those calming, connecting, pain relieving effects that our natural oxytocin release does. So that's an important point. Secondly, on the positive side, we don't think that it gives negative feedback. So this was something people have thought about, and I thought about, if you give a woman synthetic oxytocin, isn't she going to shut down her own release? Well, we don't think that this happens. We can't know for sure because when we measure oxytocin in the blood, we can't discriminate between the natural and the synthetic. But we don't think that it does. And in fact, in some circumstances, synthetic oxytocin can actually almost like fill in a hormonal gap for the woman. Yeah. I just quote something there, which is, I guess, the biggest hormonal gap, if we think about it, is women who have a pre-labor cesarean. So all those things that we've talked about, she's not ready for labor by definition, all of her systems aren't ready, then she hasn't had the benefit of all these processes of labor and birth and the brain oxytocin, etc. So she's really in the biggest hormonal gap, and her baby also. So in one of these studies, when women in that situation had their baby skin to skin on them, they actually didn't release oxytocin because of all of those gaps, unless they had quite a high dose of synthetic oxytocin. I'm not suggesting that's a panacea or we should give all women after cesarean synthetic oxytocin, but it's interesting that we create a hormonal gap and it may have a beneficial effect of filling in that hormonal gap. So what we think in normal labor, a woman getting synthetic oxytocin, if it's at low doses, it even could increase our positive feedback loop. If it causes stronger contractions, it even actually could lead to increase in brain oxytocin release. So we think that low doses are probably not harmful as far as we can tell. But what we're most concerned about is really the high doses that overstress the uterus, that work the uterus harder, that the uterus needs to work. The uterus is a muscle. It's like you go for a run. You work your muscle hard, you build up lactic acid because you can't get all the oxygen to feed your muscle cells. And then the lactic acid builds up and it gets painful. So I think that's part of the processes of labor. And if we overstress the uterus with high doses of synthetic oxytocin, it causes stress in the body, stress in the muscle, and that could shift women from all those nice parasympathetic oxytocin effects into more of a stress effect.